Thank you. Thank you to the conference organizers for inviting me to explore this topic further for the ERC meeting. I'm Dr. Welsford. I'm an emergency medicine and pre-hospital care physician from McMaster University in Canada, representing both Heart and Stroke Foundation of Canada as well as ILCOR, the International Liaison Committee on Resuscitation. So lucky to have worked with ILCOR on behalf of Heart and Stroke now for over 10 years, nearly 20 years, on correlating the latest evidence into international treatment recommendations. And today we're focusing on the post-arrest care and specifically the value and the evidence for early coronary angiography. So let's have a look. So imagine, if you would, this 54-year-old gentleman. He was complaining of some indigestion when he was lifting heavy boxes at work. He became diaphoretic and then he had a sudden collapse. Bystander CPR was provided. Paramedics arrived. They continued CPR and were able to deliver 2 defibrillations, the second of which was successful and he regained a pulse. Unfortunately, he remained comatose, and so he was transported to hospital. On arrival, they found that he was still comatose and he was in a sinus rhythm, and his first ECG showed no ST elevation. So what then are the next steps for this patient? What is the predominant post-arrest care? And myself, as well as other panel presenters, will be discussing this in terms of looking at all the factors about post-arrest care. So we're going to come back to this patient. But think, if you will, the variety of things that are going to happen in terms of caring for him. And I'm going to go on and focus a little bit on the coronary angiography part. So in terms of post-arrest care, we obviously want to optimize ventilation, oxygenation, hemodynamics, metabolics, and the neurologic care for this patient. In terms of the cardiovascular care, and that's where I'm going to focus on, we need to think about, is this likely cardiac related? Or is there an obvious non-cardiac cause? And so it's often at this time that you need to think about other causes such as PE, significant neurologic events, or other causes. But if this is presumed to be, or most likely to be, a cardiac event, acute coronary syndrome can present as a cardiac arrest. And so it may be the case for the gentleman that we had just talked about. So he's arrived in hospital and he's comatose, and you've got your initial ECG. Now, certainly there's a whole variety of things for us to think about in terms of this patient's care. Now, I think all of you would likely agree, and I'm from McMaster, so I have to represent this point of view in terms of the importance of evidence-informed care. So looking at the research evidence and making sure that we're using that to guide our care for an individual patient. So rather than evidence-based care, where the most senior physician waxes poetic about their experience, which is often very valuable, it's more than that, and it goes beyond that into a maybe not even just one randomized control trial, but rather perhaps a systematic review and meta-analysis along the lines of a Cochrane review or an ILCOR-based review. And in fact, let me tell you just really briefly about the process for those ILCOR reviews. So ILCOR does take very important questions as recommended by the councils. They are looking at that important evidence, the science, and come up with systematic reviews that are published separately and stand on their own as excellent evidence. And they use that to inform the consensus on the science and a treatment recommendation. Those treatment recommendations are then taken by the 9-member councils, and they can then have a look at those recommendations and change them into guidelines. And those guidelines can be used for education and information dissemination. And that's what forms the basis for our resuscitation plans of care for patients. So if we make sure that we stick to the evidence, let's go back then a little bit to the look at coronary angiography, early cath lab. Does this patient post-arrest need that? Now, our knowledge and our international recommendations before the last 2 years have been based on what's largely observational, retrospective predominantly single-center observational studies that have looked at both ST elevation and non-ST elevation post-arrest and looked at the benefit of early coronary angiography. If you collate through all of that evidence, there was some pretty strong signal, and that in somebody who has an ST elevation, that perhaps there was benefit from that early coronary angiography, knowing quite well that unfortunately observational, especially retrospective single center studies, without a doubt, there's some selection of these patients. So these are likely patients who are selected to have the best outcomes already, those people who didn't have any poor prognostic or had very few poor prognostic outcomes. And so for that reason, we need to be a bit careful. But certainly, if we took somebody who had a cardiac arrest and was known to have, for instance, ST elevation on their ECG before their arrest, or they woke up and they were awake and they could complain of ongoing symptoms of an ACS, those patients are likely to, more than 90%, to have a culprit artery that they'll find on coronary angiography and benefit. And in fact, their mortality for those people who are awake post-cardiac arrest with ST elevation, who get early angiography, their mortality can be as low as only about 5 or 6%. So pretty amazing survival in those patients who are treated very aggressively with angiography and obviously PCI as indicated. So what about those, though, where they're not awake, where they're comatose? And that's where we're not quite so sure. So I'm going to focus on the non-ST elevation patients, because those with ST elevation, I think that there's, because of the biologic plausibility of knowing that ST elevation patients usually do have a culprit artery, because those patients tend to do better in all kinds of other studies. I'm going to leave that, because that answer is fairly certain. Not completely, but fairly certain. However, let's talk a little bit about the non-ST elevation patients. So the COAX study was released in 2019, New England Journal of Medicine, a large study of over 552 comatose patients enrolled in a multi-center study in the Netherlands. So a randomized control prospective study, yes. So nice to finally have that published last year. And in this study, they found they took all patients who had no ST elevation, so they excluded ST elevation patients. They excluded those that had shock, had obvious non-coronary artery causes of arrest, those with refractory ventricular arrhythmias, those who were DNR or not expected to survive a year. So there was still some selection of the patients. And when they took those patients and they randomized them, they actually found, surprisingly different from the observational studies, that there was no obvious benefit to early angiography. And so in this slide, you may be able to see that the primary outcome in terms of survival of early angiography and delayed angiography, really at 64 and 67%, showed no obvious benefit from early angiography. These patients, interestingly enough, found that there was only approximately 23% of them that had an infarct-related artery that they could find that was amenable to PCI. And so for that reason, you can see how if it's such a low percentage of patients that have an appropriate lesion to take care of, that maybe it'd be hard to find the benefit in this group, and indeed it was. The DISCO study. Now, the DISCO study is great. So this is was published in 2019 was the pilot study of a much larger study that's still ongoing. This one is a multi-center study in Sweden. So hey to the Swedes. And in this study, again, they're looking at comatose survivors of cardiac arrest that have non-ST elevation. And what did they find? Okay, so it's only a pilot study. So in this pilot study, let's see, it was approximately, I think, 70 or so patients. They found no difference in survival in those strategies. And so certainly having looked at if you were to take the evidence from the DISCO study and also from the COAC study, there doesn't seem to be a lot of clear benefit for early coronary angiography. But there's more randomized control studies on the way. So we will have not just one large study, but several. So the Tomahawk study, for instance, that one is completed. It's a multi-center study in Germany with over 500 participants with planned completion this year. The additional studies, for instance, the ARREST study, from the UK. Again, the recruitment was paused earlier this year. Their 1-year follow-up would be complete next year. Hope to see that soon. The EMERGE study from France, again, they had completed recruitment last year. I believe they reported that they've recruited 337 of about 970 that were planned. And it is due to be completed in 2020 as well. The COOP study from Spain, they had completed their recruitment of about 166 patients this year with plan to have follow-up completed by the end of the year. Lastly, the ACCESS study. This was a North American study, but this, unfortunately, the study was stopped early due to low enrollment and thus withdrawal of their funds. And so they had recruited only 65 of a planned 864 patients. And so that study, I haven't seen it published, and I hope that they will publish the results for those 65 patients. But unfortunately, we won't have the results from the full trial. So let's think about the evidence that we do have to date. Okay, so out of hospital cardiac arrest, you've got return of spontaneous circulation. The patient remains comatose. The evidence for these patients, their prognosis is guarded. Now, certainly in the COAC study, close to 65% of these patients survived, but that was specific to shockable rhythms and excluded a number of worrisome characteristics, and so they had a high survival. But if you take all comers of out-of-hospital cardiac arrest who have survived to arrive hospital, certainly their survival is often less than 25%. And so the survival can be very poor, often from neurologic reasons. And for that, once you arrive, trying to make a decision about going to the cath lab for coronary angiography and PCI is quite a difficult decision. And so perhaps if we look at this, and this is based on an algorithm that was from the AHA and ACC in the US, where ST elevation patients, the thought was to go ahead and activate the cath lab, consider early coronary angiography and PCI, unless there were significant worrying prognostic features. And then for the no ST elevation patients, okay, let's try that again. Nice to get a phone call in the middle of your recording. Okay, so for the ST elevation, it was activate the cath lab for early coronary angiography unless there's poor prognostic factors. For the no ST elevation group, it was to assess them first, to consider delayed coronary angiography unless there was specific reasons why you might consider early angiography. So really assess first and consider delayed angiography. And so if we go back There we go. So if we're trying to decide early angiography or should we await and assess, we need to be careful, and it shouldn't just be, heads, you get PCI, tails, you get some baby aspirin. We really should stick with our evidence, and that's why it's so wonderful that we'll have some additional RCTs ready soon. Here is an example of some prognostic features using Utstein unfavorable resuscitation features. So here is a collection of 10 unfavorable resuscitation features, and they make sense, these unfavorable ones. People who had an unwitnessed arrest, no bystander CPR, had a long time to ROSC, had ongoing CPR, not just in the field, but also in the emergency department, had never had a shockable rhythm, whose pH is low, or their lactate is high, or their advanced age, or some comorbidities such as advanced renal status, and other causes for the arrest, such as non-cardiac causes. So this is one way that you could look at prognostic features for patients, but there are many more, and we really should be looking at other unfavorable tools or other tools to look at prognostication. And I really hope that in the future that we'll have some prospective validation. So tools like ACS2 that looks at things like the ACSS stands for preceding angina or CHF, the shockable rhythm, presence of ST elevation on the ECG, and that gives you a score for good prognosis. The CAHP or cardiac arrest hospital prognosis that looks again at age, setting, initial rhythm, duration of CPR, their pH, and the number of epinephrine doses that they received. There's also the C-graph prognostication that looks at whether coronary artery disease was known, whether their sugar is up, the rhythm, their age, and their pH. So a variety of different tools. It would be great to have these prospectively evaluated so that we could move forward with some early prognostication tools to decide on CAG. I will tell you that congratulations to the ESC, who just recently published their 2020 recommendations around care of the non-ST elevation patient post-arrest who is comatose. And they gave this a class 2AB recommendation for delayed as opposed to immediate coronary angiography to be considered in these patients without ST elevation. The 2021 ILCOR COSTAR, or Consensus on Science and Treatment Recommendation, is pending, and congratulations to Nicholas Nicolau, who is a cardiologist and is just publishing his latest systematic review on this topic that will include those two newest RCTs. With very, very soon we'll have additional RCT evidence and would be able for us to have a look at these recommendations, because I think we need to consider, do these recommendations, are these in line with the evidence, and do they cover our clinical practice? So if we went back to this patient who, one, did have symptoms potentially suggestive of ACS ahead of time, no obvious non-cardiac cause, had bystander CPR, had a shockable rhythm, had a short period of CPR, but was comatose when they arrived in the emergency department. When that person was found not to have ST elevation on the ECG, should they have only delayed coronary angiography? In most of these studies, delayed meant 4, 5, or 7 days after neurologically they had recovered. And so should we wait that long in this patient who has some actually good prognostic features? And that's what I don't think we have the answer to yet. So we have some good evidence. And so I challenge you to use all of the evidence and not just a single recommendation. So we have some evidence that says maybe we should delay coronary angiography in all patients without ST elevation. Or perhaps we should look at some of those prognostic factors, and hopefully some of the subsequent RCTs will have some subgroups so that we can look at, are there groups who would benefit from early coronary angiography and others who can wait and have delayed coronary angiography. So I'm going to stop there. I hope that you'll come join us at our plenary session for post-arrest care, where we'll be able to take your questions, be able to answer those, but also please feel free to reach me through Twitter. Happy to hear what you think about the discussion today and any questions you have, and let's consider or continue the conversation on there. So thank you very much.